Hello, I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine. I'm a lung cancer doc, and it's a pleasure here to be with an esteemed faculty to discuss these cases, very challenging cases. So before we get started with case one, if we could just go around and introduce who we are, institution, our interests, and I'll start with Dr. Bala. Dr. Bala?
Hello, everyone. My name is Sanjeev Bala, and I am the Chief of Cardiothoracic Imaging here at Washington University, and my specialty is dealing with chest CT, chest MR, and occasionally correlation with chest PET imaging.
I'm Kristen Higgins. I am a radiation oncologist at Winship Cancer Institute of Emory University, and I'm an associate professor specializing in thoracic malignancies.
My name is Tom Stinchcomb. I'm a full professor at Duke Cancer Institute in Durham, North Carolina. My specialty is thoracic oncology. I am a medical oncologist.
I'm Varun Puri. I'm a thoracic surgeon at Washington University in St. Louis, and I'm a professor of surgery here.
Let's move on to the next case. A very interesting case, a little complicated. A 37-year-old female, never smoker, has a history of interstitial lung disease related to her systemic sclerosis and with scleroderma. She's had an auto transplant. She's had thyroid cancer, post-thyroidectomy and radioactive iodine. She presents with swallowing difficulties and found to have a large mediastinal mass with workup revealing a high-grade neuroendocrine tumor of the lung. The Ki-67 is 90%. We'll look at the imaging, the multiple nodules in the right lung and the mediastinal lymph nodes. The clinical stage is a T4N2M0, stage IIIB. And she gets chemotherapy first. We'll talk about that, but has progression. And there's a lot of questions related to the role of radiation. So a bit of a complicated case, but we will get through it. So this is a patient, again, who presents with cough, some cough-induced nausea, dysphagia, and fatigue. She has performance status of 1. As mentioned, her medical history is consistent with thyroid cancer, systemic sclerosis, scleroderma, Raynaud's disease, esophageal dysmotility, I assume from the scleroderma, necrotic ulcerations of the fingers, a history of stem cell transplant in 2007, ablation operation for arrhythmia in 2002, so quite a bit of a medical history here. Her social history, she's a never smoker. She doesn't drink alcohol, and she does not use any drugs. Her family history, her brother had leukemia, and a mother with thyroid disease. So again, this patient presents with a cough-induced nausea, some dysphagia. The diagnostic workup here, and we'll talk about what the CAT scan showed, but the diagnostic workup, we'll review the CAT scan in a second. But the biopsy reveals an endobronchial ultrasound, station 7, and there was lymph node sampled, mediastinal lymph node biopsy, and a right mainstem bronchus with an endobronchial biopsy. And the pathology reveals a high-grade neuroendocrine tumor, surprisingly, from a mediastinal mass, consistent with a large cell neuroendocrine carcinoma. It's got a high nuclear grade, extensive necrosis, and the Ki-67 is pushing 90. So whether this is large cell neuroendocrine or straight up small cell, I don't know. The patient's IHC markers positive for not synaptophysin, chromogranin, and has a PD-L1 test that's 2%. Does get next generation sequencing done for this high-grade neuroendocrine tumor, which is negative for any actionable mutation. The CT scan, if we can, I'd like to go forward first and just review the images, and then we can go back. This is, and pardon my moving around here, just bear with me here. The CT scan that I'm going to show you first is from, or the only set of images is from August 21st, 2020. And there are 3 sets of images here that we will talk about. So Dr. Bala, do you want to walk us through and just tell us when you want me to advance the slides here?
Sure. Thank you, Dr. Levy. So if you look at these coronal images post-contrast, you can see that the calipers are demarcating a really large soft tissue mass that is enhancing very similar to muscle, maybe a little bit more than muscle, but you'll notice that there are these areas of a little bit of high attenuation within it. The high attenuation, which may represent some either areas of enhancement or calcium, can be helpful in making the diagnosis. So our main thought would be that we've got massive lymphadenopathy in the subcarinal region. There is some mass effect upon the vessels, which is very typical for neuroendocrine lesions. The calcium is a little bit atypical for small cell. We usually get a much more homogeneous look for small cell cancers, but for either atypical carcinoids or large cell, it's not unusual to see foci of higher attenuation. So on the next slide, we just have some images that show just the nodal mass. And again, the image on the left shows that there's some mass effect on the vessels that help distinguish it, say, from something more benign. Something like histo, where we are in the Midwest, is unusual in an acute form to have such mass effect upon the vessels. The next slide is an interesting one just because it allows us to again see the transaxial images, the large nodal mass. But if you look at the lung windows, you'll see that there are these patchy areas of ground glass. And on the very bottom row, you'll notice that there's relative subpleural sparing. So this is a very good look for what's been called nonspecific interstitial pneumonia, which is one of the idiopathic pneumonias that has a very high association with scleroderma. So this is the form that's more temporally homogeneous and collagen rich. And so she's clearly got scleroderma-associated interstitial lung disease. You'll also notice that in front of the aorta, the esophagus is very dilated. This patulous esophagus is very characteristic of scleroderma. And then finally, if you look on the image on the upper row on the left, you'll see that there's some nodules. And on some of the other lung windows, you can see that there are nodules as well. So there are multiple nodules, a very large confluent lymphadenopathy in the subcarinal region with mass effect upon the vessels, all of this on a bed of findings of scleroderma with a nonspecific interstitial pneumonia pattern and with a patulous esophagus. Now, one thing to note is in our practice, when we see patients with this constellation of findings, we often will see pulmonary hypertension findings where you'll see a very large pulmonary artery and a large right ventricle. Pulmonary hypertension often travels with scleroderma. Those findings are missing in this situation. So we have the interstitial lung disease, the nodules and the nodes, but we don't have any signs of pulmonary hypertension.
And Dr. Bala, just because this may help for our case, so you've got this conglomerate of mediastinal nodes that you're seeing there, and then are we seeing here one or two right-sided lung nodules? Can you see here? We'll read the report.
I see at least two discrete nodules. There's in the upper row, you can see that there's a nodule that's just lateral to the subcarinal lymphadenopathy, and then in the right base, on the bottom row on the right, next to the chest wall, there's a nodule there as well. And I think your comment is really very valuable because one of the things that we have found to be a real pitfall in dealing with scleroderma is that neoplasm of the lung can often take a more consolidative look and can easily be overlooked. So on the top row on the left, there's this vague anterior kind of almost consolidative nodule. We would be very concerned about that and at least follow it if nothing else were done, because that too could represent another focus of carcinoma. For some reason in the setting, especially when we're dealing with adenocarcinomas, they tend to be less nodular and much more similar to consolidation or an infiltrate in the lungs. So really have to turn your guard up when you're dealing with the interstitial lung diseases, especially with scleroderma.
Okay, so quite a bit to unpack from this set of images with a very complicated medical history. So I appreciate all of that, Dr. Bala. So I'm sorry for jumping around. I just want to make sure that we go chronologically on this case. And I just want to review the CAT scan and what it at least said here. In the CAT scan, as Dr. Bala mentioned, an interval development of confluent subcarinal and right hilar lymphadenopathy with soft tissue density, some effacement of the mid-esophagus, moderate stenosis of the right superior pulmonary vein, a soft tissue density in the right lower parabronchial vascular region, and then these multiple, as was mentioned, new right lower lobe nodules, measuring 1.6 millimeters. They're calling them multiple. Dr. Bala, I think you saw two there. And so most of the disease is confined with the lung. It's confined to the lung, but I do want to just highlight the importance of this, because in terms of staging and trying to understand what this really, where the cancer is, may help us or inform us on how we're going to come up with a treatment plan. Again, apologies for jumping around. So we have this scan, Dr. Bala reviewed it, we have the report, and going back again, the patient does have an endobronchial ultrasound. The biopsy is done, and we've already gone over the biopsy. The biopsy shows, surprisingly, a large cell neuroendocrine cancer with a Ki-67 of 90% with positive synaptophysin and chromogranin. Now, this patient receives 2 cycles of platinum etoposide. So, Dr. Stinchcomb, again, I know it's been a bit of a complicated case, but in summary, this patient presents with this imaging finding, these imaging findings that Dr. Bala went over, a pathology that's consistent with a high-grade neuroendocrine cancer. You know, can you walk us through sort of how you would manage this, whether it would be different? Does this patient need a PET scan or a brain MRI? And what would you do here? And that's not the point of the, I think there are other questions that are here on this case, but just initial management of this case.
So, Dr. Levy, we would get a PET scan and a brain MRI, really making sure that this is stage 3 disease and it's not extra thoracic sites of disease, because I think that changes the intent of the therapy from a potentially curative to a palliative approach. And we're fairly diligent about doing that in all of our potential limited stage small cell patients.
And let me just ask, let's assume, Dr. Stinchcomb, are you assuming based on the biopsy that this is more small cell, you would treat this as a small cell type of cancer? The pathology says large cell neuroendocrine, Ki-67 of 90%. Is this one where you usually treat that way?
So I think clinically I've grouped these to the high-grade neuroendocrine tumors, especially with that very high Ki-67 of 90%. And this looks to be a very rapidly growing tumor. From a therapeutic standpoint, I would think of more platinum etoposide as the backbone for any therapy at this point.
Okay. Dr. Higgins, the reason I tried to spend so much time on the radiology is to see if this is something that you would upfront manage with radiation. I'll just go back to what we saw here. You have some multiple nodules in the right lower lobe, a large confluent mass in the medial, subcarinal. Is this limited stage? Could we consider doing concurrent chemoradiation, assuming that the PET and the brain MRI are clean otherwise? Is this too big of a field, or is this something where you could consider radiation? This may be important in terms of next steps.
Yeah, I would say in the absence of the interstitial lung disease and scleroderma, with these imaging findings, I would consider this curative treatment, stage 3, assuming the PET doesn't show any surprises. So I don't think that the disease itself is too large to treat with curative intent. You can definitely get 60 gray in there without a problem. But the thing that makes this case really difficult is the patient's scleroderma and interstitial lung disease. There's certainly data for scleroderma being the one collagen vascular disease that portends higher rates of radiation side effects. You'd worry about, certainly the esophagitis with her, esophageal dysmotility that she already has. And then the interstitial lung disease in and of itself is a very big problem. I would have this patient evaluated by a pulmonologist to understand how bad her interstitial lung disease is, because it certainly is a spectrum. You have patients that don't require, oxygen and carry the interstitial lung disease diagnosis. You have others that are on continuous 4 liters. And those are the patients that I very, very, very much worry about giving radiation to, because they can have grade 5, acute respiratory syndromes and die from radiation therapy. So this is a case that you have to, I think, proceed with very, very carefully. So I would need more details on the extent of the interstitial lung disease, I think.
Okay. And maybe that's why this patient got just chemotherapy, didn't get radiation at the beginning. Again, apologies for skipping around, but I want to go to the CAT scan at least to report after 2 cycles of chemotherapy. We don't have the images. We had the images from the beginning, from August, but post 2 cycles of platinum etoposide, what we're now seeing is an increased size of the confluent mediastinal right hilar lymphadenopathy, persistent severe narrowing of the adjacent right lower lobe segmental pulmonary artery and distal bronchus, distal branches, and then these increasing multiple right pulmonary nodules now measuring 1.9 centimeters. So summary here, looked like limited stage small cell from the beginning with these multiple nodules in the right lower lobe with subcarinal lymphadenopathy, has a lot of comorbidities, was treated with 2 cycles of platinum etoposide, which did not really make a dent. So the question back to you, Dr. Higgins, and I think it's the question from the actual case is there a role for radiation here? And how would you do this? And is there a technique? Is it the same technique that you described from the get-go here? Is it just a discussion?
Yeah, I mean, I think you're really in a rock and a hard place, and whatever you do, you're probably not going to get a great outcome. But I would have a very detailed discussion with the patient in terms of what the goals of therapy are, knowing that there is a risk that she could die from treatment. But if they're not responding to systemic therapy, I think you almost have to give radiation to see if you can get some response. This patient has got to be severely symptomatic from the extent of disease in the mediastinum. I would probably start with conventional fractionation, 2 gray per day with IMRT technique, and I would probably do cone beam CT on the radiation machine daily so I can see how she's responding. The other thing that you could consider is proton therapy, because you can get a lower integral dose to the lungs and the esophagus with protons. Of course, not everybody has access to a proton therapy center, but we are giving proton therapy to some of these patients that have significant interstitial lung disease, and that can be a route to take. But if I could get in a definitive dose, I would certainly try, but I would have to have a honest conversation with the patient about the risks.
What would be that dose? Is that an unfair question given that you don't have the patient in front of you?
Well, if we're considering this large cell neuroendocrine and not small cell, then I would do 60 gray daily. If we were treating this along the small cell pathway, then I would try to give 45 gray twice daily, which is my preferred fractionation for small cell lung cancer.
Okay, one more unfair question. Let's say you give the radiation, the patient has a nice response, does well. Would you consider PCI for this patient? She's technically limited stage small cell, treated with radiation, done well. Would you radiate the brain as part of a prophylactic effort or offer it?
Well, right now, PCI is still the standard of care for limited stage small cell. So I would offer it. Again, she has an increased risk of side effects because of her underlying comorbidity. So all those conversations still have to be had. I'd probably try to enroll her on our trial of hippocampal avoidance PCI as a measure to decrease neurocognitive side effects from PCI.
Okay.
Can I ask Dr. Higgins a question, if you don't mind?
Sure.
Okay, this is a rather uninformed question, Dr. Higgins, but when you radiate someone with bulky mediastinal nodal disease and with significant pulmonary underlying disease, are there ways in which you kind of either sort of sequentially deliver radiation? Do you target the mediastinum first and then radiate the lung parenchyma, or is it all done within the same field at the same time?
Yeah, so we can draw discontiguous treatment volumes, so you don't have to cover all of the lung from the mediastinum to the lower lobe lesion. We don't do that anymore. We can avoid that with our technologies that we're using. The standard of care now is to deliver radiation to the target volume of involved disease, with IMRT technique. But that being said, there are approaches that are being looked at, like, for example, giving mediastinal radiation and then giving SBRT to the nodules, which is a very interesting approach because you can spare more lung that way. And we actually have some trials in development and the cooperative groups looking at that.
Okay.
Nice overview, Dr. Higgins. Dr. Stishcombe, a little bit of a challenging question here, but this patient has a large cell neuroendocrine, has a high Ki-67. We think of the response rate to platinum etoposide with these tumors is quite high. This patient progressed on 2 cycles of platinum etoposide, which we generally don't see, at least on 2 cycles. We have a response rate anywhere from 70 or 80%. If Dr. Higgins decides to give radiation, would you consider giving chemosensitization with something different than platinum etoposide, given the aggressive biology of this tumor?
I think I would, because I think local control is going to be really important to this patient in terms of their symptoms, and we're probably only going to have one good intervention at this time. So I think if my radiation oncologist went forward, I would probably do something. This is atypical, maybe weekly cisplatin or something, to act as a radiation sensitizer, so that we get the most therapeutic benefit out of the radiation.
Okay. I appreciate everyone's questions, involvement, input. This was a very complicated case, and certainly one that challenges sort of how we manage, and pulling data is kind of tough here. I think in summary, the decision would be to offer conventional fractionated radiation anywhere from 45 to 60 gray, depending on the tumor type. Dr. Higgins, is that reasonable?
Yeah, absolutely. And you could consider advanced radiation technologies such as proton therapy.
And protons. And then along those lines with the radiation, to consider some sort of chemosensitization regimen that is not platinum etoposide, something else like weekly cisplatin. That would be the summary here for this very challenging case. But I would say that a PET scan and a brain MRI are also part of, I would hope that they would be done here, given that there's progression, to see if there's other sites of progression. Great discussion panel. I appreciate the input.